I'd like to acknowledge the traditional custodians of the land on which I'm recording today and pay my respects to elders past and present. I'm Kate. I'm an Australian pharmacist with more than 25 years of experience working across hospital pharmacy, community pharmacy, palliative care, aged care, and now voluntary assisted dying. Welcome to Pop Pod, the clinician edition of Prescribe or Pass. Look for me on Instagram, TikTok, Facebook, and YouTube at Prescribe or Pass. Every episode explores one medicine, one condition, or one clinical concept, explaining not just what we do, but why we do it. Whether you're a pharmacy student, pharmacist, or any clinician who works with medicines, welcome to the Pop Pod. ADHD Series, Episode 1. What actually is ADHD? Welcome to the very first episode of our ADHD series. Over the next 8 episodes, we're going to build a practical understanding of ADHD from what it is and how it's diagnosed, through to how it is treated, the different classes of medicines we use, and why one person might be prescribed Ritalin whilst another receives Vyvanse, where the non-stimulant medicines fit in, common myths, common adverse effects, and the important role pharmacists play as part of the multidisciplinary team. Each episode will build on the one before it, so if you're new to ADHD, this is the perfect place to start. And if you're listening as a pharmacist, you might like to work through the entire series as a CPD activity. Across the 8 episodes, there will be around 2 hours of learning, and I'll finish each episode with a reflective question to help you document your learning and think about how it might influence your practice. This episode is the foundation for everything that follows. Before we start comparing medicines, we first need to understand the condition they are treating. So today we are going to answer 4 questions. What is ADHD? How is it diagnosed in Australia? How is it treated? And where does the pharmacist fit in? So, what actually is ADHD? Because despite being one of the most talked about conditions in healthcare, it's also one of the most misunderstood in the general community. Over the last few years, public awareness of ADHD has exploded. More adults are being diagnosed than ever before, and the use of ADHD medicines has increased dramatically. In Australia, the number of people dispensed PBS-funded ADHD medication increased from around 2 people per 1,000 population in 2004-05 to around 22 per 1,000 in 2023-24. That's approximately an 11-fold increase. And much of that growth has occurred over the past 5 years. Some of the increase reflects changes to PBS eligibility and the availability of newer medicines. Some reflects greater awareness and better recognition of ADHD, particularly in adults. And some reflects people who spent years or even decades wondering why life seemed to be harder for them than it appeared to be for everyone else, finally receiving an assessment. At the same time, ADHD has become one of the most discussed health topics on social media. That greater awareness can be a very good thing. It means more people recognize themselves in what they are hearing. It means more parents recognize that a child who is struggling may need support rather than punishment. And it means more adults who have spent a lifetime believing they were lazy, careless, or somehow failing at life are beginning to ask whether there might be another explanation. But increased awareness also brings misinformation. People say things like, everyone has a little ADHD, everyone is on the spectrum, that's why it's called a spectrum. It's caused by the rise of social media. These people just need more discipline, or they can play video games for 6 hours, so clearly they can concentrate. But none of those statements really explains what ADHD is. And if we don't understand the condition, it becomes very difficult to understand the treatment. So let's start at the beginning. I hear it's a very good place to start. What is ADHD? ADHD is a neurodevelopmental condition. That means that the brain develops and functions differently, and those differences begin in childhood, even when someone is not diagnosed until adulthood. The first thing I would like you to set aside is the name itself, attention deficit hyperactivity disorder, because the problem is not always a simple deficit of attention. Many people with ADHD can focus intensely, sometimes for hours, when something is interesting, novel, urgent, or rewarding. At other times, attention will not go where they need it to go at all. Sometimes it becomes locked onto something engaging for so long that hours disappear. Meals are forgotten, messages go unanswered, the outside world seems to fade away. And that's described as hyperfocus. So ADHD is better understood not as a lack of attention, but as a difficulty regulating it, directing it, sustaining it, shifting it, and disengaging from it when necessary. That's why some people may spend 6 hours researching Roman history, learning everything there is to know about tropical fish or building a moral aeroplane, yet still struggle to begin a 2-minute email. From the outside, that inconsistency can look like laziness, or it can look like procrastination. It can look like the person only makes an effort when they feel like it, but that interpretation misses what is actually happening underneath. Because at its core, ADHD involves difficulties with executive function. Executive functions are the management skills of the brain. They help us organize ourselves, plan, prioritize, estimate time, hold information in working memory, resist impulses, switch between tasks, and translate intention into action. Imagine a workplace full of capable people. Everyone has the skills they need. They understand their individual roles. The work matters. But the manager responsible for coordinating priorities, sequencing tasks, and keeping everything on schedule is unreliable. Sometimes the manager is highly effective. Sometimes the manager disappears. The staff still know what needs to be done, but things do not happen in the right order or at the right time. That's a useful way to think about executive dysfunction. It explains why someone can know exactly what needs to be done, genuinely want to do it, and still feel unable to begin, not because they do not care or because they are lazy, and not because they have consciously decided to procrastinate, but because the brain is struggling to organize action. And this is one of the most important reasons ADHD matters clinically. Many people with ADHD have spent years being judged according to the behavior we can see without anyone asking what's driving it. A missed deadline becomes irresponsibility. A forgotten appointment becomes careless. An emotional reaction becomes immaturity. A school report says could do better if they applied themselves. And over time, those judgments can become part of how the person sees themselves. For some adults, receiving a diagnosis is not simply about accessing medication, it's about finally having an explanation for patterns that have shaped their entire life. It's about replacing what is wrong with me with what's been happening here. And that distinction can be enormously powerful. And to understand those patterns a little more clearly, we need to talk about dopamine and noradrenaline. You've probably heard someone say ADHD is caused by low dopamine. And it's a phrase that has become very popular on social media. And like many simple explanations, there is a grain of truth in it. But it's not the whole story. To understand why, let's take a step back and think about how nerve cells communicate. Your brain contains billions of neurons, and these neurons do not touch each other directly. Instead, there's a tiny gap between them called a synapse. When one neuron wants to pass a message to the next, it releases chemical messages into the gap. Those messages are called neurotransmitters. The two neurotransmitters we are most interested in here are dopamine and noradrenaline. Neither belongs exclusively to ADHD. Both are involved in many different functions throughout the brain and body. But they play particularly important roles in the networks responsible for attention, motivation, alertness, and executive control. Dopamine is often described as the brain's pleasure chemical. That is another oversimplification. A more useful way to think about dopamine is as a neurotransmitter involved in motivation, reward prediction, and helping the brain decide what is important enough to act on. It contributes to questions such as, should I pay attention to this? Is this worth the effort? Should I keep going? Noradrenaline has a somewhat different role. It is involved in alertness, focus, and maintaining attention once a task has begun. So, as a very simplified model, if dopamine helps the brain decide where attention should go, noradrenaline helps sustain it once it gets there. Of course, the brain does not divide jobs this neatly. These neurotransmitters interact with each other continuously, but it is a useful starting point. So, what is different in ADHD? The important point is that we do not think people with ADHD simply fail to produce enough dopamine. If that were true, diagnosis would be much easier. We could measure it, we could perform a blood test, or perhaps identify a single abnormal result on a scan. But we cannot. ADHD is not diagnosed by measuring dopamine and is not simply a whole brain shortage of one neurotransmitter. A more accurate explanation is that dopamine and noradrenaline signaling within particular networks is regulated differently. One of the most important of these networks involves the prefrontal cortex. And the prefrontal cortex sits just behind the forehead, and it is sometimes described as the brain's chief executive officer. It plays a major role in planning, organization, prioritizing, regulating emotions, inhibiting impulses, and holding information in working memory. Those executive functions we spoke about earlier. When dopamine and noradrenaline signaling within these networks is not optimal, the prefrontal cortex does not coordinate those functions as effectively. That explains why someone with ADHD may know exactly what needs to be done, genuinely intend to do it, and still struggle to start. It also helps explain why interest makes such a difference. Tasks that are novel, interesting, personally rewarding, challenging, or urgent often activate these brain networks more effectively. Routine tasks do not. That's why attention can appear so inconsistent. Someone may forget to pay an electricity bill but spend hours mastering a game. They may be unable to begin an administrative task until the deadline is almost upon them, and then complete it in a burst of intense focus. So the useful question is not, can this person concentrate? It is, under what circumstances can their brain engage those attention networks effectively? That shift in thinking changes the way we understand ADHD. It moves us away from the idea that the person is choosing when to care, and towards the idea that the brain is responding differently to interest, reward, urgency, and effort. So why do medicines help? This is where the medicines we will discuss in later episodes come in. Although they work in different ways, many ADHD medicines ultimately increase the ability or activity of dopamine, noradrenaline, or both within these attention and executive function pathways. They do not create intelligence, they do not manufacture motivation from nothing, they do not change someone's personality, and they do not suddenly make someone normal. Instead, they aim to improve the efficiency of signaling in these networks so that the brain is better able to regulate attention, control impulses, and organize behavior. For many people, that does not feel like becoming somebody different. It feels like becoming able to do things they were trying to do all along. But if ADHD cannot be diagnosed with a dopamine test or a blood test or a scan, how do clinicians actually diagnose it? Diagnosing ADHD is not like diagnosing low iron. There is no single neat number sitting outside of a reference range. No blood test, no brain scan, no genetic test. ADHD is a clinical diagnosis. In other words, an appropriately trained clinician brings together multiple pieces of information to determine whether someone meets recognized diagnostic criteria. That assessment usually begins with a detailed clinical history. The clinician will explore the person's symptoms, but also how these symptoms affect everyday life. How did they cope at school? What was childhood like? How are they functioning at work or university? How are their relationships? Do they struggle with organization, time management, driving, finances, or completing routine tasks? Because ADHD is a neurodevelopmental condition, clinicians are also looking for evidence that the pattern began during childhood, even if it was not recognized as ADHD at the time. That evidence may not look like a child who was disruptive or unable to sit still. It may look like daydreaming, losing belongings, taking hours to complete homework, needing constant supervision, appearing bright but inconsistent, or relying on considerable structure from parents or teachers to function. Where possible, information from parents, partners, school reports, or teachers can help build the picture. But not every adult seeking assessment has access to childhood records, and not every parent is available, and not every child's difficulties were noticed or documented at the time. So, collateral information can be useful, but it needs to be interpreted in context. Validated rating scales are often used as part of the assessment, but it is important to understand what they do and what they do not do. Rating scales do not diagnose ADHD. They help organize information, identify patterns. They may help estimate the frequency or severity of symptoms, but the diagnosis still depends on an experienced clinician interpreting the whole clinical picture. Another important part of the assessment is considering what else might explain the symptoms. Poor concentration, forgetfulness, and difficulty functioning can occur with anxiety, depression, trauma, sleep disorders, substance use, thyroid disease, learning disorders, autism, medication effects, and many other conditions. And sometimes those conditions exist alongside ADHD rather than instead of it. So the task is not simply to exclude everything else and be left with ADHD. It is to understand what is contributing to the person's difficulties and whether more than one condition may require treatment. And finally, clinicians ask one of the most important questions of all. Is this causing meaningful impairment? Because everyone gets distracted, everyone procrastinates, everyone forgets things. A diagnosis is not made simply because someone recognizes themselves in a social media post. It is made when a persistent pattern of symptoms is affecting education, work, relationships, or day-to-day functioning in a significant way. In Australia, children are commonly assessed by paediatricians or child and adolescent psychiatrists, while adults are assessed by psychiatrists or other appropriately trained clinicians like clinical psychologists, and in some states, appropriately trained GPs. Who can initiate and continue stimulant ADHD medication also varies between Australian jurisdictions because stimulant medicines are controlled drugs. So, although the principles of diagnosis are broadly consistent across the country, the pathway into treatment may look different depending on where someone lives. And that matters because difficulty accessing an assessment can create years of delay, it can increase cost, and it can widen inequity between people who can navigate private care and those who cannot. And for the person waiting, it can prolong the belief that their difficulties are simply a personal failing. Once the diagnosis has been made, the next question becomes, what do we actually do about it? How is ADHD treated? ADHD treatment should be tailored to the individual. There is no single treatment plan that suits everyone. A child struggling primarily at school may need a very different combination of support from an adult managing employment, parenting, finances, relationships, and household responsibilities. Treatment also needs to take account of age, goals, degree of impairment, physical and mental health, family circumstances, preferences, and any coexisting conditions. For that reason, ADHD is usually managed using a multimodal approach. That simply means combining different forms of treatment and support rather than expecting one intervention to solve everything. The first step is often psychoeducation, helping the person, and where appropriate their family, understand what ADHD is, how it affects them, and what their particular strengths and challenges might be. That understanding matters. A diagnosis should not simply replace the label lazy with another label, ADHD. It should give the person a framework for recognizing patterns, reducing shame, and developing strategies that fit the way their brain functions. Psychological and behavioural intentions may also form part of treatment. For children, that may include parent or family training, classroom strategies, and behavioural supports that help adults provide clearer expectations, consistent routines, and more effective reinforcement. For adolescents and adults, cognitive behavioural approaches may help with planning, organisation, emotional regulation, procrastination, and unhelpful beliefs that have developed after years of struggling. ADHD coaching may also help some people translate intentions into practical systems, breaking tasks into smaller steps, developing routines, using reminders, creating external structures. These interventions do not remove the underlying neurodevelopmental condition, but they can help people build skills, modify their environment, and manage the functional consequences of ADHD. They may improve quality of life, self-esteem, relationships, and everyday functioning, even when their effect on the core symptoms is less pronounced than that of medication. Support may also involve a broader multidisciplinary team. Depending on the individual, that could include a GP, psychiatrist, pediatrician, psychologist, occupational therapist, nurse, pharmacist, dietitian, speech pathologist, teacher, school counsellor, or workplace support service. Coexisting anxiety, depression, autism, learning disorders, trauma, sleep problems, or substance use may require assessment and treatment in their own right. Sometimes those conditions complicate ADHD management. Sometimes treating them makes ADHD easier to manage. And sometimes treating ADHD makes it possible for the person to engage more effectively with psychological therapy or other supports. Environmental adjustments can also make a substantial difference. At school, that might involve reducing distractions, breaking instructions into smaller steps, allowing movement breaks, providing written as well as verbal instructions, or adjusting assessment conditions. At university or work, it might involve assistive technology, flexible scheduling, quieter workspaces, written task lists, calendar systems, or clearer deadlines. The aim is not to remove every demand from the person's life. It is to reduce unnecessary barriers and create enough external structure for their abilities to be used more consistently. Lifestyle matters too, but this needs to be discussed carefully. Sleep, physical activity, and nutrition do not cause or cure ADHD. And advice such as sleep more, exercise, and eat better is not an adequate substitute for evidence-based treatment, but those factors can meaningfully influence how well someone functions and how well they tolerate medication. Sleep deserves particular attention. ADHD can make it difficult to settle at night, maintain a routine, or disengage from stimulating activities. At the same time, inadequate sleep can worsen concentration, impulsivity, emotional regulation, and working memory. Treatment may therefore include consistent sleep and waking times, reducing late night stimulation, addressing an underlying sleep disorder, and reviewing whether medication timing is contributing to insomnia. Regular physical activity may support general health, sleep, mood, and day-to-day functioning. It can provide an outlet for restlessness and improve alertness for some people. Nutrition is also important both for general health and for very practical reasons. Some ADHD medicines suppress appetite. So a person who skips breakfast, misses lunch, and eats very little during the day may become tired, irritable, or nutritionally compromised even when the medication itself is improving their ADHD symptoms. Planning a substantial breakfast before a stimulant takes effect, using manageable meals or snacks during the day, and eating more when appetite returns can be helpful. A dietitian may be valuable where there is significant weight loss, restrictive eating, nutrition deficiency, sensory difficulty with food, or a coexisting eating disorder. There is no single ADHD diet supported as routine treatment for everyone. Claims that ADHD can be corrected simply by eliminating sugar, avoiding particular food additives, or taking supplements should be approached cautiously. Diet, exercise, and sleep are supportive components of care, but they are not evidence that the condition is the person's fault, and they should not be used simply to imply that medication is unnecessary. For many people whose ADHD symptoms are causing significant impairment, medication is an important part of treatment. Broadly, the medicines used for ADHD fall into two groups: stimulants and non-stimulants. The term stimulant can sound strange in a condition associated with hyperactivity, but these medicines are not prescribed simply to increase energy. They improve signaling within brain networks involved in attention, inhibition, and executive function. In Australia, the stimulant medicines belong to two families. The first is methylphenidate. Methylphenidate is available in immediate release and longer-acting formulations, including products such as Ritalin, Ritalin LA, and Concerta. These medicines contain the same active ingredient, but they release it differently. That affects how quickly the medicine begins working, how long it lasts, and how its effects are distributed across the day. The second stimulant family is the amphetamines, and it includes dexamphetamine and lisdexamphetamine. Lisdexamphetamine, better known as Vyvanse, is a prodrug that the body converts into dexamphetamine. That conversion produces a different onset and duration from immediate release dexamphetamine. Methylphenidate and the amphetamines both influence dopamine and noradrenaline signaling, but they do it in different ways. One is not automatically stronger, one is not automatically better. and one is not reserved for more severe ADHD. Some people respond much better to one family than the other. The choice may be influenced by age, symptom pattern, how many hours of coverage are needed, previous response, adverse effects, coexisting conditions, and the ability to swallow or use a particular formulation, cost, availability, and the person's daily routine. The second broad group is the non-stimulants, and these include atomoxetine and guanfacine, with clonidine used in some circumstances. Atomoxetine primarily increases noradrenaline signaling by inhibiting its reuptake. Unlike a stimulant, it does not usually produce an effect that begins and ends clearly with each individual dose. Its therapeutic benefit tends to build gradually over days or weeks. Guanfacine and clonidine act on alpha-2 adrenergic receptors. They may help regulate signaling within prefrontal networks and can be used in particular clinical circumstances, although sedation and reductions in blood pressure or heart rate may limit their use. Non-stimulants may be chosen when stimulants are contraindicated, ineffective, or poorly tolerated. They may also be considered when coexisting symptoms, the risk of misuse, sleep difficulties, tics, or other clinical factors influence the decision. In some cases, a non-stimulant is used alongside a stimulant rather than instead of one. And importantly, non-stimulant does not mean weak, it does not mean harmless, and it does not mean second-rate. It describes the pharmacological class, not the value of the treatment. Children and adults are not always offered exactly the same sequence of non-stimulant options, and approved indications, PBS restrictions, and prescribing rules may differ between medicines. We will unpack these details in later episodes rather than reduce them to a simple hierarchy here. Whichever medicine is chosen, treatment usually involves titration. The prescriber begins with an appropriate dose and adjusts it gradually while monitoring both benefit and adverse effects. The aim is not to increase the dose until the person no longer displays any ADHD traits. It is to find the best balance between improved functioning and acceptable adverse effects. Monitoring may include appetite, weight, growth in children, sleep, mood, blood pressure, and heart rate. But it should also include questions about real life. Can the person begin tasks more easily? Can they follow a conversation? Are they less impulsive while driving? Can they complete schoolwork without requiring a crisis? Does the medication last long enough for the parts of the day that matter? And do they still feel like themselves? Medication can reduce the core symptoms of ADHD more effectively than non-pharmacological treatment alone for many people. But medication does not automatically teach organizational skills. It does not repair damaged self-esteem, it does not resolve relationship difficulties, and it does not redesign an unsupportive environment. That is why good ADHD care combines symptom treatment with practical, psychological, and social support. The goal of treatment is not to make someone quieter, more compliant, or more convenient for everyone around them. It is to reduce impairment, improve safety, improve quality of life, and help the person participate more fully in the life they want to lead. So where does the pharmacist fit into all of this? This is my favorite part because people often think the pharmacist's job begins when the prescription arrives and ends when the medicine leaves the pharmacy. When people picture ADHD care, they often picture the psychiatrist making the diagnosis, the psychologist providing therapy, or the GP writing a prescription. The pharmacist is sometimes seen as the final stop, the person who hands over the medicine. But that view misses one of the greatest strengths of pharmacy: continuity. For many people with ADHD, the pharmacist is the healthcare professional they see the most often. We may see them every month, sometimes every few weeks. And over time, we watch treatment evolve in a way that few other clinicians can. That continuity allows us to notice patterns that may not be obvious during a 20-minute consultation. We may notice someone collecting their medicines later than usual, or much earlier. We may recognize that the dose has been changed several times in a short period, or that a person who used to collect their prescription every month has quietly stopped coming altogether. Those observations can become the beginning of an important conversation. When someone starts ADHD medication, one of our most important roles is education. How should the medicine be taken? How long might it take to work? What should they expect in the first few days? Which adverse effects are common? Which are not? When should they contact their prescriber? How should a missed dose be managed? What happens if they forget to eat? Many of these questions arise long after the medical appointment has finished. And they are exactly the kinds of questions pharmacists answer every day. We also help people understand that not all ADHD medicines behave in the same way. Two medicines may contain the same active ingredient but release differently. Some are designed to work for hours, others are designed to cover more of the school or working day. Some offer greater flexibility, others are designed to produce a smoother and more sustained effect. Understanding these differences help people use their medicine safely and obtain the best possible benefit for them. Pharmacists also play an important role in monitoring treatment. We are often the first clinicians to hear that someone has lost their appetite, can't sleep, feel nauseated, has headaches, finds the medicine wears off too early, or feels emotionally flat. Sometimes those effects are expected during the early stages of treatment. Sometimes they indicate that the dose, timing, formulation, or even the choice of medicine needs review. Recognizing the difference is an important part of our role. We also identify interactions, support people through medicine shortages, explain brand or formulation changes, reinforce monitoring, and communicate important observations back to the prescriber. But perhaps our most valuable contribution is something less tangible: context. People with ADHD are sometimes judged as careless, unreliable, or non-compliant. They may lose prescriptions, forget appointments, miss doses, arrive late, or struggle to follow a complicated treatment plan. And those behaviours can be frustrating, but they can also be manifestations of the very condition we are treating. Our role is not to ignore genuine concerns. ADHD medicines are controlled medicines and require careful stewardship, but good stewardship and compassionate care are not opposites. We can maintain appropriate safeguards whilst still approaching each person with curiosity rather than suspicion. Because when pharmacists understand ADHD well, we do not simply supply medicines. We help people use them safely. We help them understand what to expect. We help them identify when something is not working. And we become an important link between the patient and the rest of the multidisciplinary team. Pharmacists are not simply part of the supply chain. We are an essential part of the therapeutic team. Some reflective questions. Before the next episode, take a moment to ask yourself, what do I already understand about ADHD? Where did that knowledge come from? What assumptions have I made about it? And where are the gaps? Do I understand the difference between methylphenidate and amphetamines? Could I explain why two people with the same diagnosis might receive completely different treatments? And as a pharmacist or clinician, would I feel confident supporting someone who has just started ADHD medication? You do not need to know everything yet. That is what this series is for. But good clinical practice begins with recognizing what we know and being honest about what we still need to learn. Because one of the things I value most about healthcare is that the more deeply we understand a condition, the less likely we are to reduce the person living with it into a stereotype. ADHD is not simply poor concentration, it's not laziness, it's not a lack of intelligence, and it's not a failure of discipline. It is a complex neurodevelopmental condition that can affect the way the person learns, works, organizes, responds, relates, and moves through the world. And the better we understand that complexity, the more accurately we can diagnose it, and the more thoughtfully we can treat it. Next episode. Now that we have built the foundations, the next question is one of the most common I hear. If two people both have ADHD, why might one be prescribed methylphenidate and the other an amphetamine? Does the choice tell us anything about how severe their ADHD is? Is one class of medication stronger? And how do clinicians decide where to begin? That's next time on The Pop Pod. See you later. Bye-bye.